am Dr. Gable. I'm a professor of neurology at Duke University in North Carolina. And I'm joined today by Dr. Jeff Allen, who's a professor of neurology at University of Minnesota. And so this is a talk that is supported by argenx. I just want to highlight our accreditation statements here. And disclosures and disclaimers. We also have a planner and speaker disclosure policy as well. And these are our faculty and planner disclosures here. So the learning objectives for today, so we're going to integrate information on the pathophysiology, EAN PNS guideline recommendations for CIDP and the diagnostic pitfalls of CIDP, and also how to implement appropriate patient-specific factor-based and novel targeted therapies for CIDP. So for the agenda today, we are going to spend 30 minutes discussing the pathophysiology and the guideline recommendations and diagnostic pitfalls with a pre and post-test question. And then Dr. Allen will also be doing the second portion for 30 minutes discussing patient-specific factor-based and novel targeted therapies for CIDP. And afterwards, there'll be some time for a panel discussion. So first, we'll start with a pre-test clinical vignette. So this is a 56-year-old patient with well-controlled diabetes, presents with symptoms of numbness and tingling affecting the hands and feet, progressive proximal and distal weakness affecting the upper and lower extremities for over 3 months. Which of the following features on the electrodiagnostic testing would most definitively confirm the diagnosis without a need for further supportive testing? So here we have A, conduction block greater than 30% in both ulnar motor nerves in the forearm segment, with absent sensory nerve conduction responses in both sural nerves. Or B, conduction block of 30% in only one ulnar motor nerve in the forearm segment and absent sensory conduction responses throughout the upper and lower limbs. C, low amplitude motor responses in all the motor nerves. Or D, sensory nerve conduction responses absent throughout the upper and lower limbs. So we'll give you a little time to take a look at that. And we'll be discussing the answer of that at the end of this first portion. So first, I'm going to talk about the definitions of CIDP, the pathophysiology, the guidelines overview, and a little bit about diagnosis and pitfalls with diagnosis. Just as for context, it is a rare disease. The incidence is 0.2 to 1.6 per 100,000 per year, with prevalence of 0.8 to 8.9 per 100,000 per year, and a median age of onset of 40-60 years, and a 2-to-1 ratio of men to women. With typical CIDP, the clinical features include a relatively symmetric proximal and distal weakness in the upper and lower extremity, as well as sensory changes like numbness, reduced reflexes or areflexia throughout. And this needs to evolve importantly over a very particular timeline of 2 months or more in a progressive or relapsing pattern. Electrophysiologically, as part of the diagnosis, you also see evidence of peripheral nerve demyelation, which we'll look at a little further. And then sometimes, so other data is needed to support the diagnosis. And some of those include a spinal fluid analysis, where you're looking for albumin-cytologic dissociation, imaging, where you're looking at MRI for either nerve root enlargement or enhancement at the cervical or lumbar nerve roots, or cross-sectional area enlargement in non-compressible sites, primarily along the median nerve or at the root level of the brachial plexus. Histologically, you can also see segmental demyelination or inflammation of nerve biopsies, and then clinical improvement with immunomodulating agents is also part of the supportive criteria, and also excluding other common things that can come up to look like mimics, like hereditary neuropathy or malignancies, anti-MAG neuropathies, MMN, or others. There are variants, so that's the typical type, and then there are CDP variants. So distal, meaning hands and feet symmetrically affected with sensory and motor weakness. Multifocal or Lewis-Sumner syndrome, typically upper extremity predominant and asymmetric, also involves weakness and sensory changes. A sensory variant is symmetric sensory changes, and a motor is pure motor weakness that's also symmetric in the upper and lower extremity. So a little bit of context about the pathophysiology of CIDP. So this is probably maybe potentially a figure you've seen before, but here we kind of summarize the involvement of both the innate and adaptive immune system with CIDP. And so you have what initiated with macrophage binding that leads to demyelination, and then complement cascade is triggered as well. Then there are also involvement of T and B cells, with T cells triggering B cells to produce autoantibodies to an unknown antigen as of yet. You have T cells that are generating inflammatory cytokines and chemokines, and then an increased production of complement as well, and kind of a cascade that leads to destruction of the coating of the nerve or the myelin. So as an overview of that, just as a refresher for what is in the innate and adaptive immune system, the innate immune system, primarily the portions of that are involved or known to be involved with CIDP include what was just mentioned with complement and macrophages. And then also in the adaptive immune system, you have humoral immunity. So the responding cell is a B lymphocyte, and the effector mechanism is the antibody. And then you have cell-mediated immunity. So that includes the helper T cells, which have their effect by generating cytokines or activated macrophages, an activation of T and B lymphocytes. And then the responding cells are cytotoxic T cells, which have a direct attack on affected cells. And then there's also the T regulatory cells, and these suppress inflammatory response. And so we know there's a dysfunction of that with CIDP as well. So this is really an issue with immune tolerance. With self-tolerance, the body normally has a process to recognize the self versus outside antigens, and that would inactivate and not have attack, but this is a loss of self-tolerance leading to the autoimmune disease. And so, as I said, as an overview, we have this innate immune system, the adaptive immune system. There are no clear triggers and no known antigen at this point. There is a breakdown of the blood-nerve barrier, and then that leads to segmental demyelination near the nodes of Ranvier, and inflammatory cell infiltration seen to include lymphocytes and macrophages. So with macrophage involvement in CIDP, this can be seen in both atypical and variants. The macrophages have been observed surrounding myelinating fibers, and in T fiber preparation, segments without myelin are noted secondary to macrophage-related phagocytosis. And electron microscopy, you can also see myelin debris in cytoplasm of macrophages. So this is a nice pictorial view of that. In the summary at the top, you'll see a T fiber preparation of a nerve, and the portion that has less delineated by the arrows here is the area where you have segmental demyelination. In this epoxy resin embedded photo, you have evidence of macrophages surrounding a myelinated area. And then in this one is electron microscopy with a kind of box cutout of close-up view of myelin debris inside this macrophage surrounding the myelin here. So those are the macrophage demyelinating characteristics of that part of the innate immune system. The other portion is the complement cascade that occurs in the complement activation. And so just as a review of that, there are three ways to get to the end terminal lytic pathway. And so you have the classical pathway through the C1 activation, then the lectin pathway, an alternative pathway that lead to a sort of self-renewing activation at the C3 level that then leads to C5 and then terminal lytic pathway at the membrane attack complex. So there are some proof of concept things here to show the role of complement in CIDP. Complement deposition on nerve fibers in patients with CIDP is found even in those nerves from patients with CIDP. Even on as of not yet demyelinating fibers, you could find complement deposition there where you did not see that in controls. And then complement pathway activation in serum and CSF. So there was a small study with 21 treatment naive and newly diagnosed CIDP patients versus controls, and there were higher levels of serum and CSF C5a and the terminal complex complement levels in CIDP patients. And interestingly, With that study, they showed that higher disability correlated to higher complement levels, and that with treatment with IVIG reduced those levels that correlated with improvement with NCAT scores. There was also a interesting assay that was developed to look further into this proof of concept of complement involvement in CIDP with the human on a chip model of autoimmune demyelinating. And so how this works is that this assay was developed to grow neurons on a microchip, and then they had electrodes underneath those neurons, and then you could stimulate them and generate a conduction velocity. And so then you could use the serum from patients and controls to evaluate if there was slowing of conduction velocity, depending on if there was demyelinating activity occurring. And that's what we did see when we put the serum from patients with MMN and CIDP on these neurons. And then you can apply the C1s monoclonal antibody, and that actually blocked the deposition of complement and reversed the conduction velocity slowing in this model. So very interesting. Moving on to adaptive immunity in CIDP, there are diverse mechanisms that include macrophage and complement, but you also have this loss of tolerance with T regulatory cells being generating sort of being dysfunctional essentially in CIDP, so they're not able to suppress the immune response with the other T cells that are producing inflammatory cytokines. And so there's some evidence to show that when they looked at T regulatory cell function, it was impaired in CIDP patients. And then also sometimes the frequency was either increased or decreased, but in all the studies, it did show that T regulatory cell function was impaired in patients with CIDP as compared to controls. And we've also seen similar findings in mouse models. And the adaptive immunity in CIDP, there are different, as I said, T helper cells or cytotoxic cells, and then the B cells that generate antibodies. And so we've seen a little bit more evidence for involvement of T helper cells with increases in inflammatory cytokines there, and also on deposition and infiltration in nerve biopsy. There's less clear translational evidence in CD8 T cell evidence, but we have seen it in nerve biopsies and blood and T cells of upregulation of those cells as well. And then in B cells, we don't have other antibodies really identified in the last a little bit of time. There has been the identification of an IgG4-mediated antibody disease that we now refer to as paranodopathies that looks clinically like CIDP and electrodiagnostically often like that. And I have a figure of that, but there's the contactant antibodies and neurofascin 155 antibodies that importantly respond better to B cell suppression, like with medications that can target B cell suppression than with other treatment modalities. And so that's an important thing to recognize for patients. I think here we have more to learn about antibodies that might play a role in this disease. And we know there's a treatment effect with the treatments that can reduce antibodies, like efgartigimod with this IgG reduction and plasma exchange as well. Here is an image of those, the area, the juxtaperonode, and node. And in the peronode, as we call them, paranodopathies, because these antibodies that have most been connected pathologically to disease-causing entities is in the peronode and the neurofascin 155 targeted antibodies and the ones to contactin 1 here. So I would say that the pathogenesis of CIDP, there's still much to be learned. We have innate and adaptive immune system involvement. We have unknown trigger or target antigens. We have unknown antibodies unidentified for the most part as of yet. There can be an aging impact on the immune system, and that can affect CIDP immunology as well, and the variants versus typical CIDP, and understanding how those change over time. Switching over a little bit to how you can then move on to diagnosing CIDP, I'd highly recommend using these guidelines as a reference. They're not a research criteria. They're meant to be used as a day-to-day reference for how to diagnose and also to manage CIDP. Initially, the first revision was published in 2010 in a collaboration with the European Academy and also the Peripheral Nerve Society. And then the second iteration from 2021 was developed, which still has a fairly high sensitivity and specificity for diagnosis and improves kind of variant diagnosis as well. So when we get into the diagnostic criteria, just speaking mostly for the most part for the most common type, which is the typical CIDP, which is that symmetric proximal upper and lower extremity weakness and sensory loss and areflexia. You have CIDP with the clinical criteria that meets that clinical criteria, and then you need to have strongly supportive electrodiagnostic criteria, and we'll look at that too. But essentially, that means 2 motor nerves are affected, and also at least 2 sensory nerves are affected in order to meet the criteria for CIDP. Secondarily, if you have the clinical features, but maybe only 1 motor nerve is affected with demyelinating characteristics, then that's really weakly electrodiagnostic criteria that's been met. And then from that point, you have to look for other things to support the diagnosis. And that would include spinal fluid or imaging or response to treatment. Or nerve biopsy. Sometimes we rarely do that, but that's sometimes necessary. If you find 2 or more of those supportive features are present, then you can kind of upgrade that to being a CIDP there, if there's no alternative explanation present. With respect to the electrodiagnostic testing, I'm not going to read all through this. This is meant to be a reference also for you to use on hopefully a regular basis for looking at your studies to see if studies meet the criteria for the diagnosis. And as I said, you need to have 2 nerves that meet these strongly supportive demyelinating characteristics. And if it's only in 1 nerve, then it's weakly supportive of demyelination. The features you're looking at are motor distal latency prolongation, reduction in motor connection velocity, prolongation of F wave minimum latency, or an absence of F waves in at least 2 nerves, and a greater than equal to 30% reduction in the conduction block in a non-compressible site. So not across the elbow, not across the fibular head, but in a non-compressible site that can meet those criteria, and abnormal temporal dispersion, and then duration as PCMAP as well. Sensory nerve connections, assuming the patient's appropriately warmed, as noted there, with good quality control for temperature control, because as you know, that can reduce, slow things down and kind of look like it's slower than it really is, increase amplitudes. So you want to make sure that you have the appropriate skin temperature maintained when you're assessing this. But these are also included in the new iteration of guidelines for looking for sensory nerve connections as well. With respect to imaging, in the guidelines, primarily most of the evidence supported looking at the median nerve across the length of the nerve. So from the wrist all the way up to the axilla, even up into the kind of interscaling area of the plexus and nerve roots, which is a little trickier to do. However, if you meet 2 or more of those sites of proximal median nerve enlargement in non-compressible sites, then in the forearm or upper arm primarily are the highest yield, then you can meet supportive criteria. MRI is also helpful. You can get with and without contrast to look for enhancement or enlargement at the nerve root level. With respect to CSF, albumin-cytological dissociation, so you're looking for a minimum of 5 to 10 nucleated white blood cells or less, and elevated CSF protein, considering age-related changes as noted in the references here that I would allude to that you could take a look at to look at more details of this, but primarily just keeping in mind that you can't use spinal fluid as a primary means to make a diagnosis. You need to have, this is something that's supportive for the diagnosis, assuming that the electrodiagnostic and clinical phenotype also raise suspicion for CIDP. And the other things can influence the protein levels, including spinal stenosis or diabetes. Nerve biopsy, rarely needed, but sometimes needed if you're trying to rule out other things primarily too. So what we're looking for here are thinly myelinated axons and small onion bulbs, thinly myelinated or demyelinated internodes and teased fibers, perivascular macrophage clusters there. So when you're looking at the differential for within, this is also within the guidelines there as in a summary of that, but for each of the variants, you need to consider sort of particular things that might be mimics or red flags that might make you want to look into other things. And so one would be with the distal CIDP, where just hands and feet are affected, you want to consider a family history, as you could potentially be running into someone who has a hereditary neuropathy. And so the chronology of that of evolution of disease is also important to consider. If you have a lot of autonomic involvement or pain, which is a little atypical really for CIDP, then you might want to consider diabetes or amyloidosis or hereditary TTR amyloidosis potential diagnosis instead. With ataxia or tremor and distal CIDP, predominance happens with the autoimmune nodopathies. So you can consider checking for those neurofascin and contactin antibodies. Looking for axonal causes of neuropathy is important. Always checking an SPEP and immunofixation testing for all the CIDP patients to ensure that you don't have a monoclonal protein or potentially a MAG antibody there. That's actually a different entity of anti-MAG neuropathy. And then sensory CIDP, just considering, that's a really tricky one. So you want to consider other causes too, because there's could be a lot of things contributing to that as listed here, especially if there's not definitive demyelinating features. And looking for diabetes or B12 deficiency or other common causes of axonal neuropathy. Family history also to be considered. Rarely you run into an entity called CISP, but for the most part, those are the mimics there. And then multifocal or Lewis-Sumner CIDP, any kind of pain would be, a lot of pain would be a big red flag, and considering other entities in this one where you do a nerve biopsy to exclude like a vasculitic process, or considering other conditions like Parsonage-Turner or diabetic amyotrophy. If there's normal sensation, but multifocal pattern of conduction block, you might need to consider MMN as a possibility. There's family history, hereditary neuropathy of pressure palsies is also a possibility as well. And then, considering entrapment or trauma or tumor if only one nerve or limb is affected. With motor CIDP, that's a big, broad differential. So it could be anywhere from your motor neuron disease to myasthenia gravis, or MMN or inflammatory myopathy. So really considering all those features when you have someone that has no sensory symptoms, but has symmetric proximal and distal weakness, and looking for other causes. One of the supported features, as we discussed, is looking at response to treatment. And I would encourage you to pick one or all of these, if you can, for looking for metrics to assess response to treatment. And so there are outcome measures that are commonly used in clinical trials, like the NCAT score, or secondary outcome measures like the Rasch Overall Disability Scale, or just grip strength, which is a very effective measure over time that you can use to look for and assess for response, or our neuroexam, which is includes the MRC sum score essentially, and is easy to measure. We have these minimal clinically important differences that are established for these to look in combination with assessing the patient, the history, and the exam to kind of give you a little bit more objective information to look for a response to treatment. Yeah, and so ultimately, just considering all those features, you have to look that the misdiagnosis rate is still quite high. So I think the main takeaway from this is that I would really encourage you to use those guidelines as a reference on a regular basis to kind of consider all these other potential contributing mimics to diseases, and to follow patients over time closely, and definitely every 3 months at the beginning, and consider every 6 months if you have an established diagnosis. But because things can change over time, and sometimes they're not always so clear cut, and there can be gray zones. But I think ultimately, using what we have for the guidelines for diagnosis will help reduce this misdiagnosis rate. And some of the common pitfalls that you can use when considering some of the supportive data when you're looking at that, when you have someone who maybe meets possible criteria but not quite, and you're looking for the other kind of things to support that diagnosis. Well, when you're looking at nerve conduction studies, making sure that if someone has a lot of axonal loss or reduction in amplitude on the responses, that you're not attributing this mild or moderate demyelination to axon loss, and losing those fast-firing axons can happen, and you can overcall a nerve conduction study being demyelinating when it's really not, especially in the presence of someone who has diabetes that can cause a mixed demyelinating axonal neuropathy on the electrodiagnostic studies. Placing an overstated importance on CSF protein elevations, or using that in isolation for the diagnosis, especially if a patient's over 60, especially in the presence of diabetes or lumbospinal disease. So just kind of considering that the levels need to be a little more generous than 45 milligrams per deciliter if you're looking at that. And oftentimes thinking more in like over 100 would be more definitive per milligram per deciliter if someone has all these conditions and they're over that age range, to be more considered more supportive, although there is no clear definitive cutoff at this point. Overhauling imaging findings, I think ultrasound might be one area where it's very useful if you're very familiar with how to use ultrasound, but being careful at even those nerve root levels, that can be very tricky if you don't have experience. So making sure that whoever is generating that data has experience with using that. And then looking at improvement, quote unquote, improvement after immunotherapy is a diagnostic test that is a part of the supportive criteria, but you really want to try to be as objective as possible when you are when you're assessing improvement, so that it's not just subjective changes of fatigue is improving. It needs to be really more substantial than that to demonstrate a real objective response to treatment. So using some of those strength or disability outcome measures are very helpful for that. You can, I'd say there's also delayed and misdiagnosis is also very common. So you can have a misdiagnosis, but also just missing the diagnosis entirely. So it kind of goes both ways. So I think in these trials, it kind of reiterates, how long it has taken some patients to get diagnosed. So there's a delay and a lot of nerve damage. And then also there's people who are kind of overtreated and overdiagnosed too. So it comes back to like kind of looking at the diagnostic criteria and trying to use those to your best advantage. So key points here are recognizing characteristic clinical and electrophysiologic features, and that's key for earlier and accurate diagnosis. Supportive features are not diagnostic of CIDP in isolation. You start with the phenotype, then you move to electrodiagnostic criteria, and then you consider the supportive findings, not the other way around. You need to consider mimics and red flags, and supportive data is definitely helpful if you have a suspicion based on the clinical symptoms and the electrodiagnostic data, but you need a little bit more help to make the diagnosis. And then really looking at all those like kind of differentials to consider other diagnostic alternatives that can crop up even later, and the variants can be especially difficult. So like I said, clinical phenotype plus electrodiagnostic testing, excluding mimics, obtaining diagnostic support testing when necessary, and being vigilant and following the patient closely. So I will talk about the last post-test question here before I transition over to giving over to Dr. Allen. So again, the 56-year-old patient with well-controlled diabetes presents with symptoms of numbness and tingling affecting the hands and feet, progressive proximal and distal weakness affecting the upper and lower extremities for over 3 months. Which of the following features on the electrodiagnostic testing would definitively confirm the diagnosis without a need for further supportive testing? And then we have here the A, conduction block of over 30% in both ulnar motor nerves in the forearm segment with absent sensory nerve conduction responses in both sural nerves, or B, only one motor nerve is affected and then sensory conductions are also affected. C, low amplitude motor responses in all the motor nerves, or D, sensory nerve conduction responses absent throughout the upper and lower limbs. And I think I can put in, there's some data here. Yes, so glad that got through to some people. I think here, A is the correct answer. You need the clinical phenotype, and then next, the electrodiagnostic testing demonstrating demyelinating characteristics in at least 2 motor nerves and absent sensory nerve conduction studies in at least 2 sensory nerves to meet the electrodiagnostic and phenotypic characteristics to make the diagnosis for CIDP definitively, and then you can go ahead and start treatment. So with that, I will close here and stop sharing and then allow Dr. Allen to share his screen so that he can go on to his portion of the talk.
Well, thanks. I'm going to shift gears a little bit and talk less about diagnosis and more about treatment, actually all about treatment, thinking about what our standard of care treatment is, what the evidence tells us, and then what some emerging therapies are and what we might look forward to over the next couple of years. To begin, we'll start with another pre-test case. So in this case, this is a 54-year-old woman with CIDP. She's treated with IVIG 1 gram per kilogram every 3 weeks, pretty standard dose. After 6 months of treatment, she experienced a modest but meaningful improvement in her symptoms, but she continues to have upper and lower limb weakness and numbness. She also endorses a predictable pattern of wearing off that starts about a week before each IVIG infusion. She works full-time as a school administrator and finds the infusion schedule difficult to adhere to, which results in her missing work days and prolonged visits to the infusion center. But she otherwise tolerates IVIG pretty well without adverse events. So the question is what the most appropriate next step might be. And some options might be continue the IVIG at the current dose and frequency, or to increase the IVIG dose by 25% per infusion, or shorten the treatment interval to every 2 weeks and monitor over several IVIG cycles. Another option might be to switch to subcutaneous IG, and a fourth option might be to think about switching to an FcRn inhibitor. So a couple of different choices that you might have. So keep those in mind as we kind of continue our discussion, and then we'll come back to that question at the end. And so thinking about treatment and trying to tailor treatment to individual patients can be fairly challenging with CIDP, in part because we don't have clear biomarkers which direct us towards any particular therapy. So I think one of the best approaches is to really starting with where the evidence is, and thinking about what evidence-based treatments are and how we can involve those evidence-based treatments based on outcomes and different clinical characteristics. So during this talk, I'm going to introduce an illustrated case, which I think highlights some of the challenges that we encounter when we're trying to decide upon treatment in clinical practice. So for this case, this is a 9-month, this 62-year-old man has 9 months after symptom onset, and was diagnosed with CIDP. And his symptoms include progressive weakness in the upper and lower limbs, sensory loss in the hands and feet. By the time he was evaluated and diagnosed, he needed a cane to walk, and he struggled with routine hand tasks. He was otherwise relatively healthy, other than some mild hypertension and arthritis. His nerve conduction showed unequivocal evidence of peripheral nerve demyelination, so he satisfied a high degree of certainty that he had a demyelinating neuropathy. Another notable lab work showed that he had no monoclonal protein on immunofixation. So he had a fairly convincing diagnosis of CIDP, and thinking about starting a first-line treatment. So the question is, where do we start? Options might be IVIG, subcutaneous IG, corticosteroids, plasma exchange, or articulon. We have some data on all of these. So where do we start treatment? Well, let's go through each of these and talk about what the evidence is that informs their use in CIDP, and then some pros and cons of each. One important resource is, of course, the EAN-PNS guidelines, the same guideline that Dr. Cable talked about earlier with diagnosis. That guideline also contains a wealth of information about treatment, and about how to think about these treatments sequentially as we work through different treatment protocols with patients with CIDP. And what the guideline really highlights is that when we start a treatment, it's important to start with something first that's evidence-based, and those include IVIG, corticosteroids, and plasma exchange, assessing for objective treatment benefit. If we do not see an objective treatment benefit, then rethinking about the diagnosis before switching therapies, and if the diagnosis is confirmed, then going to another effective evidence-based treatment. In patients that are on maintenance therapy, and thinking about how to optimize those therapies before really folding in other off-label treatments is one approach. But this is a good resource to look at. Well, we can dive into each of these options in a little bit more detail. And the first is corticosteroids. So what's the data that supports the use of corticosteroids in CIDP? So corticosteroids, of course, mimic the action of naturally occurring hormones. They have a number of properties that suppress inflammation. By suppressing migration of leukocytes, they affect capillary permeability, and they inhibit the pro-inflammatory and promote anti-inflammatory cytokines. So clearly, for many diseases, they're used as an anti-inflammatory medication. And like many drugs, they have their pros and cons. Of course, the pros and cons of corticosteroids are well known, I'm sure, to everybody in the audience. But some of the pros are that they're very accessible, they're easy to administer, it can be oral or IV. They're broadly effective, they're very cheap and readily available and easy to take. The cons are also well known: high blood sugar, high blood pressure, effects on bone health, gut health, weight gain, insomnia, trouble sleeping, restlessness, and other things. So often an okay treatment for the short term, but something that's not very desirable for long-term management. The data in CIDP is actually quite thin. There's really only one randomized controlled study of corticosteroids in CIDP, and that was done back in the 1980s by Dr. Dick and colleagues. And it was not a placebo-controlled study. It's actually a study where they put some patients on corticosteroids and others no treatment, and they followed them over time. Found the patients that were on steroids got better, and the patients that were untreated, were stable or got worse. And on the basis of that trial, it was established that corticosteroids were effective. Now, since then, there's been many open-label studies, and if you combine all those studies together, the response rate to corticosteroids in CIDP seems to be about 60%. We've also got some other steroid studies that are not compared to placebo, but do things like compare pulse steroids versus daily oral steroids, or pulse steroids versus IVIG. And what those studies have suggested was that pulse steroids may be a little bit better tolerated, but both protocols seem to be effective and generate similarly effective efficacy results. And consequently, those corticosteroids are importantly used in clinical practice. Those studies were also of interest in that they showed that there was perhaps a small percentage of patients that after treatment with corticosteroids had some durable benefit even after the steroids were stopped. That's certainly something that is not definite, but was one observation in a couple of those studies. So moving to IVIG and subcutaneous IG, immunoglobulins in CIDP, by far, we have the biggest depth of data for support for use in CIDP. So immunoglobulins are, of course, antibodies that are pooled from blood donors. They're spun all together, and they're administered in the form of IVIG or subcutaneous IG. Why actually they work in CIDP is uncertain. It's unknown. However, we think that they may be interacting with the disease at a couple of different levels, either by competing with pathogenic antibodies or blocking FcRn receptors and destroying pathogenic antibodies. They seem to impair T cell activation as well, and they probably also interfere with complement to some extent. So one or multiple of those mechanisms may be what's underlying the benefit with IVIG and subcutaneous IG. They also have their pros and cons, the pros being that they have the strongest level of data in CIDP. They're generally well tolerated, though there are certainly some side effects. They're not immunosuppressive, which is one big advantage of the immunoglobulins. It's not immunosuppressive like some of the other options we use. They can be either IV or subcutaneous administration, so there's a couple of different routes there. And their beneficial effect is relatively fast. In the case of subcutaneous IG, you also get autonomy, which is a potential benefit, although for some patients that don't like the subcutaneous injections, that's a con rather than a pro. Some of the cons with immunoglobulin maybe their inconvenience. The infusions are typically quite lengthy, with IV lasting from 3 to 5 hours. Subcutaneous infusions can be an hour or two. They're expensive medications. There are certain local side effects with subcutaneous IG, and systemic side effects with IVIG, including headaches and nausea, and then there are thromboembolic risks with both. So balancing these pros and cons is, for every patient is important. For the data for CIDP, IVIG has very high quality data, 5 randomized clinical trials, over 200 patients randomized, clearly show that IVIG is effective for improvement of strength and improvement of disability. Response rates in the trial vary from about 54% to over 90%. This response rate variability probably has to do with the makeup of the patients that were enrolled in the trial, with some response rates with patients that are more treatment naive, lower, and those that are treatment experienced higher. But overall response rate is quite good, between 60 and 90% roughly. Based on those trials, a typical starting dose of IVIG is 2 grams per kilogram loading divided over 3 to 5 days. And the typical maintenance starting place is 1 gram per kilogram every 3 weeks. Although, of course, in clinical practice, there's some variability with that as we try to optimize treatment with individual patients. Patients that respond to IVIG typically do so by 3 to 6 months. It's relatively uncommon for somebody to not respond at all at 6 months and then have a later response. For subcutaneous IG, we also have pretty good data. There's 2 large randomized placebo-controlled trials. Both studies were designed the same way, where patients were randomized to either one of the subcutaneous IGs or placebo followed over time, and they're looking at relapse rates. The difference in the two trials was that one drug was a straight up subcutaneous IG product. The other was subcutaneous IG combined with hyaluronidase, which is called facilitated IG. And that combination with hyaluronidase allows you to essentially administer more subcutaneous IG under the skin at any one time. So you essentially can get IVIG-like doses of subcutaneous IG administered at a frequency of every 3 to 4 weeks, whereas conventional subcutaneous IG is typically a smaller dose and administered more frequently, typically once per week. But both trials showed that the drug was clearly effective, showing that both were effective for prevention of relapse in the withdrawal period, with a difference between the drug and the placebo rate of roughly 25 to 30% in both studies, showing that it was effective for prevention of relapse. So for dosing for conventional subcutaneous IG, it's typically dosed 0.2 to 0.4 grams per kilogram once per week, and for facilitated subcutaneous IG, typically around a gram per kilogram once every 3 to 4 weeks, although dosing may be quite variable. So moving on to FcRn inhibitors. FcRn inhibitors are kind of the new therapeutic that was recently approved for treatment of CIDP. The FcRn mechanism is a fairly slick mechanism in which the inhibition of the receptor essentially tricks the body into destroying or to eliminating IgG and presumably pathogenic IgG autoantibodies. So the FcRn receptor lives on endothelial cells. As Ig moves through the blood, the vasculature, IgG is taken up by these cells and then tries to bind to the FcRn receptor. If IgG binds to that receptor, then that IgG is put back into circulation. If an IgG fails to bind to the receptor, then it's destroyed by the lysosome. So the FcRn receptor is the body's basically sorting mechanism where it can sort through IgGs, decide which ones should be destroyed and which ones should be returned to circulation. Now, if you have a pathogenic IgG autoantibody, it's also going to take advantage of this FcRn receptor and try to compete with regular IgG in order to bind the receptor. And if it binds, then it is also put back out into circulation and continue to do whatever mischief that it's trying to do. So an FcRn inhibitor then has a very high affinity for the FcRn receptor. It outcompetes IgG and IgG autoantibodies, binds the receptor, it blocks it. So consequently, all of that IgG, not all of it, but much of it, gets instead not put back into circulation, but gets destroyed by the lysosome, and presumably pathogenic IgG autoantibodies have the same fate, where they get destroyed by the lysosome. Turns out this mechanism typically drops IgG level by about 70% in most studies that have looked at it. So one FcRn receptor inhibitor, efgartigimod, was recently studied in the ADHERE study, published a couple of years ago. This was a large randomized placebo-controlled trial, had a number of different phases where patients were first required to go through an adjudication process to make sure that the diagnosis was quite likely. Patients then, if they were on standard therapies like IVIG or steroid, were asked for those therapies to be suspended in a run-in phase. The idea was to see if patients had active disease. So during that run-in phase, patients had to show some evidence of deterioration. If they were deteriorated, then they were allowed to go to the stage A. So for stage A, patients were put open label on efgartigimod. The patients that got worse in the run-in were put open label in stage A. Then they had to show evidence of clinical improvement in stage A over a 12-week period. And then those patients that improved were allowed to go on to stage B, which was the randomized placebo-controlled withdrawal phase, where patients were randomized to either efgartigimod or placebo, followed for up to 48 weeks, and we're looking for a relapse rate during that 48-week period. So on the basis of this design, we could get two main outcomes. The first was the percentage of patients that improved open label in stage A, and then number two was the percentage of patients that relapsed during the withdrawal with blinded portion of the study in stage B. The stage A results showed that about 2/3 of patients improved, 66 to 70%. The difference has to do with the way the study was designed. It was an event-driven design, so at the time of the the study was closed, there were still patients in the treatment process. So 66 to 70% of patients improved in stage A, open label, and then moving on to stage B, it was observed that the relapse rate in those patients that were randomized to efgartigimod was about 27% versus those within placebo, which was about 53%. So overall, that led to a 61% relative risk reduction of relapse in those patients which were on efgartigimod, and hence the study met its primary endpoint and consequently got approved for the treatment of adult patients with CIDP. Efgartigimod, like all our other therapeutics, has pros and cons. The pros include the efficacy data now confirmed in the ADHERE study. One of the big pros to efgartigimod is also its easy use relative to some of our other therapeutics. It's a subcutaneous injection. It's one needle administered once per week, and it takes about 60 seconds to do 30 to 90 seconds. So relative to some other therapeutics, fairly easy for patients to do and convenient. Can be administered with a pre-filled syringe. There are some local side effects, but otherwise it's fairly well tolerated. You do get into drop in IgG levels, so something you need to keep an eye on infection, but thus far infection hasn't been a major concern in most studies. And importantly, there's no IV access that's needed. Some of the cons may include, this is a targeted therapy, so it's not going to be effective for all patients with CIDP. I think the same case could be said for most therapeutics that we use. But especially with the targeted therapy, we really need to be thoughtful about who we put on the medication. And in fact, it has been observed that there's a small percentage of patients that seem to worsen as they transition from IVIG to efgartigimod, and we need to keep a close eye on that. And another con is the cost. It is quite an expensive medication. So thinking about our illustrative case here, what would be a reasonable first-line therapy? In a newly diagnosed patient, IVIG, yes, of course, this would be a very well-accepted first-line therapy. Subcutaneous IG, not unreasonable, but probably not your first choice, in part just because, for IVIG, you get that bigger improvement, increase in the IgG level in the vasculature. Subcutaneous IG will still get you there, but it's going to take much longer because it's a much gentle way to get immunoglobulin into your vasculature. Indeed, there are some studies that have shown that starting with subcutaneous IG still gets you that benefit, but it just takes longer. And we typically like patients early on to improve as quickly as possible. Corticosteroids would be a reasonable approach for first line, probably not a great long-term option, but reasonable approach first line. I didn't talk about plasma exchange data. There's some fairly thin data that plasma exchange works, and it's an acceptable first line treatment. Challenges with plasma exchange are really just tolerability and logistics over the long term. And then efgartigimod also would be something to think about as a first-line treatment, but considering that the data is relatively new and not quite as robust as we have with the long history of IVIG data, has an uncertain role in truly first-line treatment. So let's talk a little bit more about this illustrated case. So this person started IVIG, 2 grams per kg, followed by 1 gram per kilogram every 3 weeks, pretty typical protocol. After 6 months, she noticed that weakness persisted in the upper and lower limbs, but was unequivocally improved. So got better, but with residuals. No longer needed a cane walk for ambulation. Some hand task difficulties remained, but was able to perform all tasks. Some of the challenges with IVIG that were encountered were included in lengthy infusions, IV infusions, which were time-consuming and burdensome, and some systemic side effects, including headaches and delays with each infusion. So the next question is, after 6 months of treatment, you've got some benefit, but still residuals. You've got an okay tolerability profile, but not great. It's inconvenient, and there's some side effects. What do you do next? So next, your options might be to continue IVIG, but to try to modify the dose or the frequency and to improve tolerability, or thinking about switching to subcutaneous IG, or thinking about switching to corticosteroids, or switch to efgartigimod. So these are all treatment considerations. Now, when we're trying to optimize treatment or individualize it to patients, it can be quite challenging because we don't have that test, that biomarker that says this person is optimally treated or this person is optimally treated with this specific drug. But we know that some attempts in order to personalize and optimize treatment is really important. And this is indeed reflected in the EAM-PNS guideline, where it's stated in that guideline that it's recommended that patients that are clinically stable make dose adjustments to their immunoglobulin over time, periodically, to try to find the optimal dose in that individual patient, and also if that treatment is continuing to be needed. We know that about 20 to 30% of patients with CIDP enter a state of drug-free remission at some point during their disease, and the only way to understand that fully is to taper treatment. The other side of the coin is true as well, where although some people we can get away with less immunoglobulin over time, some people need more. So optimizing treatment to even more frequently than every 3 weeks is needed for some patients, perhaps 20 to 30%, or adding additional treatments. But some approach to optimizing is needed. The challenge is how best to do that, because we don't have evidence-based protocols on how to optimize to individual patients. The role of subcutaneous IG as a maintenance therapy really kind of is really supportive of the maintenance therapy for subcutaneous IG. So this is perhaps where subcutaneous IG has its biggest role, in that it can really be an effective alternative treatment to IVIG in those patients that really struggle with IV access, or systematized side effects of immunoglobulin. Or want to have more autonomy, as patients with subcutaneous IG can often administer subcutaneous IG themselves. So it can be a preferred option in some of those patients. It's not great for all patients. Some patients don't like the self-administration portion of it, or the local side effects that occur with subcutaneous administration. But it can be a helpful option as a replacement for IVIG in some patients. Corticosteroids as a maintenance therapy is not a great option for all the reasons we've discussed before, mainly the side effects that accumulate with lengthy dosing, especially in moderate to more disease. I mentioned previously some of the studies that looked at the role of pulse corticosteroids or daily oral prednisone, suggesting that there may be a durable treatment outcome in some patients. And so trying to use corticosteroids for briefly, looking for a more prolonged treatment response is a reasonable consideration for some patients, but it doesn't work for all patients. Another cautionary note with corticosteroids comes from observations about what might happen in patients with some of the variants of CIDP, in particular the motor variant of CIDP, where it's been observed that there's a percentage of those patients that actually worsen when treated with steroids, unlike other types of CIDP, but very similar to what we might see in multifocal motor neuropathy. A similar observation has been reported in some patients with multifocal CIDP. So in patients with those particular phenotypes, I think most would suggest that staying away from steroids as a treatment option is a good idea. Now, the role of FcRn inhibitors is something that we're learning a lot. It's relatively new to the treatment scene, so how to adjust and identify the ideal patient for it as an FcRn inhibitor is something that's a work in progress. It has been observed that there's been some patients that worsen immediately after transitioning from IVIG. The frequency of that deterioration seems to be uncommon, probably 5%, roughly, but it does happen in some cases, and it seems to be happens in those people that are coming from IVIG. So I think it's something that to keep in mind when you're transitioning patients, and how to best transition them is not entirely certain, but transitioning about a week after IVIG makes, I think, the most sense, while you're not at your peak IgG levels, but also not at your trough. You can more smoothly transition to an FcRn makes sense. And I think it's also important to stay away from patients that may have an IgM monoclonal gammopathy. Remember that an FcRn only impacts IgG levels. It does not impact IgM or IgA at all. So if you've got a disease which is IgM or IgA driven, it's certainly not going to help. And in fact, may take away the IgG, that was helping keep the disease in check and start with. So keep that in mind when considering transition of patients to an FcRn inhibitor. So going back to our case, what would make sense in this patient that's got some but an incomplete response to IVIG and struggles with some tolerability? Should we continue IVIG, but with the dose or frequency adjustments to improve tolerability? That would be reasonable if you've got somebody with a stable disease. If they've got a lot of treatment-related fluctuations, then if you reduce the dose or frequency, you're probably going to run into trouble. But if you're very stable, then that would be a reasonable to try to find a balance between tolerability and efficacy. Switching to a subcutaneous IG would also make a lot of sense if a person would prefer a subcutaneous approach. So if they're looking for something that's more independent, more autonomous, and they don't mind administering themselves, that would be a reasonable option here. Steroids, switch to steroids, maybe in the short term, not a great long-term option for all the reasons we've discussed. And switching to efgartigimod is also a reasonable consideration, especially if immunoglobulin tolerability or some of the feasibility logistics of getting immunoglobulin or subcutaneous IG are issues. I think one important message is that whatever you do, whenever we switch therapies, if we're reducing IVIG, switching to something else like steroids or subcutaneous IG or efgartigimod, close monitoring during those switch periods is really, really important. Made a lot of noise about the potential deterioration after switch to efgartigimod, but switching any of these roles, I think we have to closely monitor with some of the outcomes that Dr. Cable discussed in order to really make sure that we're capturing patients if they do relapse and also recording them if they have stable and also recording them if they improve, which is a possibility with some of these switches. So the field's moving towards targeted therapies, and efgartigimod is one good example of that. We're really just moving towards therapeutics that really target specific components of the immune system, in this case, IgG autoantibodies. But as Dr. Gable discussed, there's a lot more to it than CIDP, where we've got cellular mechanisms, we've got humoral mechanisms, complement plays a role. So thinking about each of these different components and what we can target and make a potential improvement in the disease is an exciting future approach to the disease management and treatment. So we've now got approved efgartigimod, based on the ADHERE study. There's multiple other FcRn antagonists that have completed trials or currently in trials. The trial that's been completed is a study called IMVT 1401, which was a drug called batoclimab. That's an FcRn inhibitor that with a study design that was very, very similar to ADHERE, where there was adjudication, run-in phase, open-label stage A, and then a withdrawal stage B. That study has been completed. We don't have the full results of this study, although some top-line results have been made publicly available. Keep in mind, these haven't gone through full peer review, but what we know about the study, what's been released to us, has been that there seems to be a response rate that overall is similar to what we've seen in ADHERE in stage A. However, what was reported was that response rate differed based on how deeply the IgG dropped. Were patients that had a drop in IgG level below 70% of baseline had an 84% response rate, and those that had a less than dramatic drop in their IgG, less than 70%, only had 44% response rate. Those patients that through week 12 also showed benefits in their disability IROD scores, their strength impairment MRC sum scores, and their strength impairment grip strength, suggesting that in that stage A open label, the drug was effective, perhaps related to the depth of the IgG reduction. Although, again, keep in mind, those are not published results, but publicly available results. That drug has subsequently been, I understand, abandoned by the manufacturer, in part because its impact also not only on IgG levels, but on lipid and cholesterol and albumin levels. Consequently, the drug is not moving forward in clinical practice or clinical trial, but the next generation of that drug, called IMVT 1402 or AMA is now currently in clinical trials, and that drug is thought to be just as potent as batoclimab, but with less impacts on either albumin or cholesterol. So that study is kind of a slimmed down version of the ADHERE study, where essentially it's cutting out the run-in stage and also stage A, where patients after adjudication are going straight toward the study drug, randomized to drug or placebo, looking at relapse rates. That study is currently enrolling. And there's also another study called the RISE trial with a drug called nipocalimab, another FcRn inhibitor that's also currently enrolling. We should get results of that trial within the next year or two, I would imagine. That study is very similar to ADHERE with the adjudication, run-in, open label, and then withdrawal stage. So multiple FcRns currently in clinical trials. Complement studies are also in clinical trials, so we know complement plays a role. The exact target for complement is not entirely worked out where the best complement target is, but it seems to be upstream in the classical complement pathway. In our current drugs that are in trials, they're going after C2. In the case of empasiprubart, or approximately it's activated C1, as in the case of riliprubart, clasiprubart. Much of the enthusiasm of these drugs comes from this open label trial of riliprubart, where patients that were on standard of care or refractory or naive were were put on riliprubart. And the results showed that patients on standard of care had a stability rate of almost 90%. And even more notable was that about half of those patients, 52%, had improvements that were above where they were on their standard of care. The patients that were considered to be refractory also had similar results, were 50% improved, where previously they were thought to be not refractory to standard treatments. And then the naive group also showed improvement in about 3/4 of patients. So these were very exciting results and led to the development of actually 3 ongoing clinical trials. One is that same drug was studied in those, which is riliprubart. This is currently in a study which is designed to be head-to-head to IVIG. So you get IVIG and placebo riliprubart, or riliprubart and placebo IVIG, followed over 24 weeks, and looking for a percentage of patients that are improving. That study is in clinical development or currently enrolling right now. Another study with a different drug, an activated C1s inhibitor named claseprubart, is currently in trials. Slightly different design here. These patients are put open label on claseprubart, looking for patients that improve, and then those improving patients are randomized to continue claseprubart or a placebo, and then we can look at a relapse rate similar to what was done in it here. That study is currently enrolling. Then a third study looking at paseprubart, which is a C2 blocker, is designed very similar to the riliprubart study, where it's looking head-to-head at IVIG. You're looking at improvement over 24 weeks. So that study is also currently enrolling. Moving on to B-cell depleters, so we've used rituximab off-label for a long time in CIDP. The data has never been very strong, although there are some case reports and series that suggest that about 60% of patients with CIDP improve. So that drug has also been studied in a Japanese study that's not been published quite yet, and an Italian study that actually has been published. In the Italian studies, patients with CIDP were randomized to either rituximab or placebo. Everybody was on IVIG. Patients got rituximab at the start of the trial and then continued their IVIG for 6 months. At 6 months, rituximab was repeated and IVIG was stopped, and the outcome was determined at 48 weeks. Essentially, any change in the disability scores, relapse rates, or strength impairment scores. And the final results show that there was essentially no difference between the rituximab group and the placebo group. The response rates were at 12 months were essentially identical, 63% versus 67%. One interesting observation was the time to relapse in both groups, where patients on placebo relapsed on average 2 months after IVIG was stopped versus the rituximab group, which was 5 months. And if you looked at outcomes 2 months and 4 months after IVIG was stopped, they tended to favor the rituximab group. So although this trial was a negative trial, I'm not sure it closes the door completely on rituximab, or certainly not on B-cell depletion therapy. And it might just mean that we're not getting the depth or durability of the response that we thought we were. So there's a number of unmet needs in CIDP that remain. How can we best tailor treatments to individual patients? I think we're beginning to understand that a little bit, but there's a lot to be learned. How can we offer treatments that for patients that have minimal response, and identify those patients with the bigger capacity to improve? Much of that discussion, I think, is going to involve biomarkers of disease activity, which is behind our discussion points today. We need to learn how to maintain or improve upon efficacy of standard treatments, and then future therapies should also take into what we're learning about the immunobiology of CIDP. But whatever we select, it's really got to be a shared decision treatment process, where we think about patient preferences, comorbidities, access and tolerability to different therapies, to jointly come up to a decision on what the best therapeutic is. When we had few therapeutic options, there was less to discuss. But now, as we've got more options on the table that are evidence-based, it's really important to balance all of these things. Is the treatment working? Are patients getting better? Are the side effects tolerable? And is the burden of administration acceptable? And ideally, finding something that optimizes all three of these things is really where we want to see the field going. So a few final comments about the immunobiology of CIDP. We know it's involving a number of different mechanisms, and although we don't have any specific pathogenic antibody in most cases, we think that antibodies play a role. We know that the guidelines are a good, important resource in order to direct first-line therapies and how to escalate therapies. We know our evidence-based therapies include immunoglobulin and corticosteroids. We now know, based on the ADHERE trial, that efgartigimod is an evidence-based therapy. Most patients improve, and it's clearly effective for prevention of relapse. And as we move forward, trying to balance these shared decision-making processes, especially as more therapeutics come onto market, and it's going to be really, really important to get the best outcomes, the least side effects, and the best tolerability for the therapeutics going forward. So thank you so much for your time. I think I'll roll over to the post-test clinical vignette that we talked about to begin with. So again, this is a 54-year-old woman treated with IVIG every 3 weeks, 6 months of treatment, experienced a modest but meaningful improvement in symptoms, but residuals remained. She also endorsed wearing off about a week before each infusion. Worked as a school administrator, found difficult to adhere to the frequent infusions. She missed work and due to the prolonged infusions, but she otherwise tolerates IVIG well. And the question is, what is the next best step? Either IVIG at its current dose, or to increase the IVIG dose by 25% or shorten the infusion, or switch to subcutaneous IG, or switch to an FcRn inhibitor. Take your responses here. So we've got a few responses here. We've got a number of votes for FcRn, a few to sub-Q, and then some adjustments to the IVIG. I think this is one of those questions where there's probably a few reasonable things to consider. I think for optimizing IVIG in this case where there's some tolerability and some end of cycle wear off, it's probably not going to go too far. If we spread out the infusions, probably going to get worse if there's already end of cycle. And if we increase the dose, we're probably going to run into more logistical and side effect issues. Transition to subcutaneous IG, I think, would make some sense. The problem there may be that we're not getting a really marked benefit from IVIG in the first place, so getting more out of that is probably unlikely. Although it's a reasonable option to switch to something like subcutaneous IG to optimize tolerability. I think FcRNs probably make the most sense in this situation. Looking at a different mechanism of action, something that's very convenient, might be helpful for our overall quality of life and lifestyle. So I think that's probably the best next option. But subcutaneous IG is something to think about as well. I think with that we can close it and offer any questions if there are any. We have a couple of questions in the chat box here. The first one is, which diagnostic test is generally considered most sensitive for supporting a clinical diagnosis of CIDP, and are appropriate tests available at community medical centers? Dr. Gable, do you want to take that one
on? Sure. So I think probably the electrodiagnostic testing is considered the most sensitive, and that should be available at most kind of places. I think ideally looking for a certified lab if that's in your area by like ANEM or something like that to make sure the quality of the testing is good. But that's probably what I would say about that.
So I agree with that. For sure, nerve conduction is most important outside the clinical features in order to make the diagnosis. It's a widely available test. Keep in mind that there are some GBS CIDP centers of excellence that have been labeled by the CIDP GBS Foundation. They're not available in every part of the country, but there's 30 or 40 of them, I think, across the country. Great resource if you're looking just for a one-time second opinion, or somebody else to kind of take a look at that patient nerve conduction. So those centers are accessible on the GBS CIDP Foundation website. Another question is, are first-line treatments like FcRn and complement inhibitor treatment available at community medical centers or only at tertiary medical centers? I think it's a mixture of both. I think a lot of them are available in both environments, but some of the newer therapeutics may not be readily available. I guess the other caveat with that is that complement inhibitors are still in clinical trials, so they're not available anywhere for treatment of CIDP. And the only FcRn that's commercially available is efgartigimod. So I would think that's got widespread availability, but I would talk to your local pharmacy team in order to understand the options at your particular site. Any other? We got another question here. I'm going to give this one to you, Dr. Gable. How do you differentiate polyradiculopathy spinal stenosis from CIDP?
Yeah, so I would say, first of all, spinal stenosis is a radiologic diagnosis. So that is actually not something that you diagnose electrodiagnostically. And then polyradiculopathy, while CIDP is kind of historically was referred to as a polyradicular neuronopathy, you can get nerve enlargement enhancement. That's something that the needle exam or the electromyography can give you information about to determine if there's a radiculopathy versus peripheral neuropathy. And so the electrodiagnostic criteria that we use for the supportive diagnosis is actually really referring to the peripheral nerve findings. And then usually you have nerve conductions, and then the EMG or the electromyography is kind of like goes along with the nerve conductions to kind of differentiate between whether it's a peripheral nerve problem versus a radiculopathy.
Well, great. Well, I don't see any other questions here, so I think I might wrap up the session. I want to thank the audience for being in attendance. Thanks MedNet for hosting this event, argenx for your generous support for the events, of course, Dr. Gable for your expert insight, and thanks for everybody for watching. Have a
Thank
great
you.
day.